Hey everyone, today we move towards the last topic of the eyelids, that is the tumors of the eyelid, right? So before we even start, let me make one thing clear, right? Eyelid is the outer part of the eyelid is at least that's the skin, right? And there are except for maybe a few of these carcinomas, most of them are actually skin cancers, right? They're skin carcinomas. So they're not specific, they're not very restricted to specifically to the eyelid, right? For example, basal cell carcinoma, squamous cell carcinoma, right? These are the kind of carcinomas or capillary hemangiomas, right? These are the kind of cancers or tumors which are not actually specific to the eyelid, right? But because the eyelid is, of course, skin, so that's why we have to study this, right? And because of the reason of its non-specificity, we will not be. I'll try not to go too much into it because we're not studying dermatology. We are studying ophthalmology right now. So there are malignant tumors, right? And there are benign tumors of the eye, right? Let's get to each one of these. So basal cell carcinoma is one of the commonest type of skin cancer, right? It's basically skin cancer, and it can occur anywhere on the skin. It can occur on the nose, on your hands, and even on the eyelids. That's why we're studying it here, and it is slowly growing, right? It is not very invasive, it is not very aggressive, it grows very slowly, it is non-invasive, right? And it is non-metastasizing. This is very important, right? Because it is one of the very few cancers which are not actually dangerous because they don't metastasize. They just stay there, they don't invade, they grow very slowly, and because they're on the skin, they're very, very visible. And as a result, most of the times, basal cell carcinoma is not actually a big problem. And when we talk about basal cell carcinoma of specifically the eyelid, its frequency it occurs like this, right? Most of the time it occurs in the lower eyelid, then followed by the medial canthus, right? Followed by the upper eyelid, and then followed by the lateral canthus. I'm sure you know what canthus means, but okay. Here's the nose, for example, and here's the eye, right? This angle, right, where the upper and lower eyelid meet, this is called a canthus, right? This is the medial canthus, this is the lateral canthus, right? So location, most of the time, basal cell carcinoma, you'll find it mostly on the lower eyelid, right? Then followed by the medial canthus, which is very dangerous because you can see medial canthus BCC or basal cell carcinoma has a very poor prognosis. We'll come to that later. Then followed by, according to its frequency, it is followed by basal cell carcinoma of the upper eyelid, and then basal cell carcinoma of the lateral canthus, right? And the reason why medial canthus basal cell carcinoma is actually dangerous, it has a poor prognosis, is because it has a tendency to move towards the inside, and from here it has the chance to infect the lacrimal system, right? Invading the lacrimal system, specifically the canals and the nasolacrimal ducts and stuff, right? And from there it can spread. So medial canthus basal cell carcinoma is not good, right? It's kind of dangerous in its way. And the risk factors of someone getting skin cancer is sunlight exposure, right? Sunbathing. People like truck drivers who are exposed to the sun the whole day, they run a fair chance of developing basal cell carcinoma. And fair skinned people, because they have less melanin in their skin, right? Melanin, as we know, is the black pigment, and it is protective against the harmful rays of the sun. So white-skinned, fair-skinned people are fairly susceptible to basal cell carcinoma, specifically the ones who are exposed to sunlight. So types of basal cell carcinoma can include the nodular type, right, where it forms this, for example, this is the skin, it forms this nodule, right? Nodule, simple. Nodular type. Most common type of basal cell carcinoma is this nodular type, and the skin, it is a shiny raised nodule, as I drew right here, with telangiectasis, right? So you'll see that it's red. It's red. It has a lot of blood vessels going through it, right? Spider webbing through it, telangiectasis. And if it is ulcerated, right, in the center, that would be called a rodent ulcer, right? It'll still be a nodular type basal cell carcinoma, but it will be a more specific kind of nodular type, right? The rodent ulcer. And then there is another form called the morphea form, right? This is less common, but it is more aggressive. And instead of being raised, it's flat, right? It's flat, and its borders are indistinct. Unlike this, which there's normal skin here and normal skin here, and there's this red spot here. Its borders are not very well defined, and it's more aggressive, and it is less common. Treatment, well, generally when we talk about treatment of cancers, it's radiation, surgery, and chemotherapy, right? Simple. Then there's, especially in cases of basal cell carcinoma, there have been certain special techniques developed to tackle basal cell carcinoma. These include stuff like laser microsurgery, right? Cryotherapy using extreme cold, and Mohs microsurgery, right? Mohs microsurgery, I'll link a video up here probably. Let's move towards the next one. That is a squamous cell carcinoma. Again, a cancer of the skin, right? It is not the most common, it is the second most common, right? The most common is basal cell, second most common is squamous cell. And again, this can occur anywhere on the body, anywhere where there is skin, and it can occur on the eyelid too, and that's the reason why we are studying it. The second most common skin cancer, and it has a tendency to spread to distant parts. That is a very distinctive thing about this type of skin cancer. Remember, in the last one, we studied that basal cell carcinoma is non-metastasizing, right? This is metastasizing. This has a tendency to metastasize. It has a tendency of spreading to distant parts, right? And site, unlike the other one, it could occur in lower eyelid, medial canthus, upper eyelid, and lateral canthus. Squamous cell would usually be confined to the lower eyelid most of the time, right? Appearance would be, it would look flat and keratinized, hardened structure, right? And ulcerated. And it also has types, nodular, ulcerative, and Bowen's type, right? Nodular and ulcerative, it's similar to the last one. Bowen's squamous cell carcinoma, or Bowen's disease, is when the squamous cell carcinoma is very, very superficial, right? So Bowen's type is the least dangerous of all this, right? And it can be removed via surgery easily. And of course, we have cryotherapy, right, to remove it. Chemotherapy and surgery and radiotherapy, they're used in most of the cancers. And again, Mohs microsurgery again. And then we have sebaceous gland carcinoma, right? It's eyelid, it's skin. Skin has sebaceous glands. And the eyelids have sebaceous glands, like the Zeiss gland, right? The Zeiss gland. The Zeiss gland is a sebaceous gland, as we studied in the very first lecture number 1, right? And meibomian gland secretes meibum, and it can also loosely be classified as a sebaceous gland. So sebaceous gland carcinoma can arise from either the Zeiss or meibomian gland, and there are 2 types: the nodular type and spreading type. Not really important to discuss the differences between them, and then you can look it up in your book if you're interested. Then treatment, surgery, chemo, and radiotherapy, right? Just like most of the cancers that we study. I know. You might be thinking, well, I'm not really explaining, or I don't sound really enthusiastic about these. That's because, as I told you in the very start of the lecture, most of these things are actually related to dermatology, right? And we are not studying dermatology right now. We are studying ophthalmology, and that's why I'm not really endeavoring to go really deep into it. I'll just memorize it, and you should do the same. Just memorize it, and that's it. Then we have KERATOACANTHOMA, right? KERATOACANTHOMA is actually a kind of a squamous cell carcinoma, right? Squamous cell carcinoma, remember the last one? It is a skin lesion that erupts in sun-damaged skin. Again, sun damage, right? And usually it resolves by itself. And its source is primarily hair follicles. So hair follicle, you can think of it as a hair follicle cancer, right? KERATOACANTHOMA, and it resolves by itself. It's not really problematic most of the time, but if it does get problematic, then you can always do surgery, right? Capillary hemangioma, right? So blood angio vessel, blood vessel oma, the blood vessel cancer, right? Which blood vessel? Capillary. So it's a capillary cancer, right? A tumor of, forgive me, I keep calling it cancer. I should be calling it tumor. So it's a tumor of of capillaries, right? And it usually arises in children. So the tumor of the blood vessels, which occur in children, right? And appearance is a red strawberry-like appearance, which is a little bit raised. Let me show you a picture. This is Wikipedia, so I hope there is no copyright claim or something. Capillary hemangioma looks like this. This is the skin, right? And underneath the skin we have capillaries, and some of these capillaries have somehow started dividing abnormally, forming this strawberry-like mass, and this is called a capillary hemangioma, right? Red strawberry-like appearance is raised, as we saw, and treatment is it usually resolves on its own, right? Up till it may stay there for like 6 to 7 years, but almost 80% of the cases they resolve by their own. At the age of 8 or 9, they usually go away, and steroids and surgeries can also help if they don't go away. Then we have the I keep saying this wrong, xanthelasma, right? Xanthelasma. Okay, let me show you first a picture of how xanthelasma looks like. So xanthelasma is this, right? And if you see it's a soft, flat, slightly elevated yellow plaque found on the skin. Yellow plaques. They're found on the skin of people who are usually who suffer from hyperlipidemias, right? Especially an increased cholesterol level, but that's not always the case. There can be xanthelasma without people having hyperlipidemias, right? Treatment of xanthelasmas include surgical excision, right, and monitoring, observing your level of lipids in case you have hyperlipidemias, right? And yeah, that's it. I think that's about it. We've covered most of the important ones. There were a few others in the book which did not seem really important, and you could look them up in the book as always. And yeah, that would be it. Thank you for your patience. Thank you for watching. I hope you liked it. And we are done with the eyelid. Our next chapter would be most probably the lacrimal system, right? So yeah, see you there. Thank you.